handing over to you.
You are recording. Okay, so before I launch into the sort of official thing, I thought I would give you a sense of why I wanted to do this. So I'm part of a research group at Rutgers, a research lab really at Rutgers University, and which is in New Jersey and New Brunswick. Cancer Institute of New Jersey, which is an NCI designated center, is affiliated with Rutgers. And the lab that I'm in is in the School of Public Health. And one of the things that we are looking at is, in terms of data, is medical aid in dying. Some people call it physician-assisted death. Some people call it euthanasia. That's not an American term. That's an other, European Canadian term. And when we've been looking for data in our lab, I realized that perhaps the patient voice wasn't quite as embedded in this process as it should have been. So the presentation is mainly to give us, in case we don't all have sort of the common language of medical aid in dying, that we could have that so that then it could inspire conversation afterwards and sort of see where we are as advocates and see kind of if it's something that has entered your thought before. If it's something that has not, then that's totally fine too, because this is one of those topics that you either want to talk about it or you don't. And sometimes you never want to talk about it, and that's totally fine too. So that's my little spiel ahead of time. Okay, so in the USA, and this is the USA has a very conservative view of what it is. The European view is a little bit more open, but the USA is the very conservative view. It's patient-initiated, physician-aided medical assistance, typically using a lethal mixture of drugs prescribed by a doctor, and the patient must administer them to themselves. If it's Canada, if it's Europe, if it's Switzerland, it could be a doctor giving you a lethal injection. That is not what we do in the USA. It's much more just, I like to call it, it's a little bit conservative. So at the moment, there's only 10 jurisdictions in the US that it is legal to access physician or medical aid in dying. We call it medical aid in dying in our research group because I think we do it. I don't actually have a reason for why we do that, but I think we do it because it takes the physician out of it. It's really medical aid. It's not, so the physician, there's sort of no implied blame. That's my take on it. I really don't know the answer, but. So there's our 10 jurisdictions. New Jersey actually is the most recent, I believe. We just started in 2019. And we are very bad at keeping data. From what I understand at the moment, there's about 11 people in the past 2 years that have accessed medical aid in dying. But because we're not very good at keeping or sharing data yet, it's still something sort of very new and tender almost in New Jersey, that I'm not entirely convinced that it's been 11 or sort of, because we've also approached them to share their data, and they are willing to share data, but we haven't gotten any yet. So being willing and actually sharing are two different things. So who qualifies? So in general, there's sort of one law that's sort of spread around to all the 10 different jurisdictions. It's all versions of the same law. So generally speaking, you being the patient, need to have 6 months or less to live. There have to be 2 primary care physicians, unaffiliated, who have qualified this and agree that you have 6 months or less to live. You must be of sound mind. So when you request it, you must be of sound mind. If there's any questions about the sound mind part, then a mental health professional will also need to be consulted. So then that could need 3 opinions and agreeing opinions that you are both of sound mind and have 6 months or less to live. You need to have the ability to self-administer the medication, which brings up 2 issues. If you are very frail or just not strong in your hands, you might have a difficulty twisting off the caps. Also, as an ALS patient, perhaps you're going to have a hard time swallowing. Not even ALS, but in other countries, you can use it for dementia. And sometimes swallowing is an issue in that setting as well. And you have to have established residency in your jurisdiction. So you can't go travel to California and decide to do it. You can, however, go to Switzerland and decide to. So why choose medical aid in dying? So this is a quote from a study which is in Canada, because it's actually legal in the entire country of Canada. So the most prominent theme was that people believed it was important to have autonomy and control over their lives, and they wanted to decide for themselves when their suffering was too great and when they wanted to have, options that included MAID. And then also, just on Tuesday, today's Thursday, right? Just on Tuesday, I heard a Fresh Air podcast, and it was Katie Engelhardt. She wrote a book that just came out this month, which I wish I had known about like 3 months ago. But her reporting said it had to do, when she questioned people who were accessing medical aid in dying or who were choosing it, it really had to do with losing control of your bowels. She said it really was about sphincter control, because the question that came up when she interviewed doctors often about this, the questions that their patients asked were often, am I going to poo when I die? Or, I don't want my children to wipe my butt. So it's really that bodily control piece and not wanting to give up that kind of autonomy. And because I just ordered her book today, and it will come tomorrow, Dispatches on the Right to Die, The Inevitable. You should listen to the podcast. It was awesome. It's on the NPR website. So what do people want? And this, again, is also what Katie talked about in her podcast interview. People generally want a peaceful, reliable, safe, and legal way to die in a way that feels dignified. And the safe and legal comes into play because there is a group of people, it's sort of called the Euthanasia underground. There's kind of this, because that's sort of one of the pushbacks of pushing for, like, why do we need laws that give people access to medical aid in dying? They can just commit suicide. Well, maybe you don't want to do something that feels illegal or feels not sanctioned or feels uncomfortable. Because if you're committing suicide, let's say that you and your family have agreed, we're just gonna, we're gonna help mom, or we're gonna help grandma, or we're gonna do whatever we can to sort of ease her on. But if people are in the same room as you, when it happens, it raises legal obligations or legal liabilities. And that's not something that we want. And people who are choosing medical aid in dying don't want to push that liability to their families. So the safe and legal piece becomes really important. However, if you're in a state or a jurisdiction, I think then we're calling it jurisdiction because DC is not a state and it's legal in DC. So if you're in a jurisdiction where it's not legal, there's this kind of underground network that exists. And that raises sort of a different access question, which is, well, if you can, first of all, access the people who are part of the underground, and then can afford to do the thing that they're suggesting you do. Some of it is perhaps in Mexico, for instance, it's legal to euthanize your own pet. So you can go to Mexico, say, hey, I need to euthanize my dog, get the drugs, bring them back to the US, take care of it that way. But maybe you can't afford to get to Mexico. Then there's Switzerland. Actually, we refer to it as suicide tourism in Switzerland, which I don't know, that's my dark sense of humor. I actually think it's kind of funny. But the problem with that too is that you have to get to Switzerland. And what seems to be the policy issue here with this sort of suicide tourism piece is that our policymakers seem to be perfectly comfortable knowing that American citizens are going to Switzerland so that they can have medical aid in dying. And actually in Switzerland, it's one of the countries where it's actually you're injected by a doctor. And typically it's also filmed in case there's a legal question at any point. but they will happily let you come into their country, do what you need to do to get the approval process, and take care of it there. You cannot leave with the medication. You take care of it right there. So practices that are in place already is sort of an interesting kind of idea in the sense that, well, we don't have medical aid in dying in certain places, but we have hospice. And when you're on hospice, or even if you're not on hospice, you are permitted, and it's actually kind of a right to have access to all the pain medication that you need to control your pain. So that's called palliative sedation or passive euthanasia. So a physician can give you enough pain medication that you go unconscious. So it's sort of this sideways piece where you're not necessarily participating in medical aid in dying, but it's a real fuzzy line, because, you know, what's the line there? Is it just slightly too much palliative sedation? But this was an issue that was raised again in Katie's in the NPR podcast, is this sort of piece where she wanted to make sure it was paid attention to what the practices that doctors were participating in that were not necessarily being counted as either suicide or medical aid in dying. And then there's there's a really bizarre what's that called? My mind's drawing a blank. Bit of data where vocabulary sometimes escapes me, where researchers will say that between 1 and 52% of the deaths are from palliative sedation. Well, that's not even like a real piece of data, because it's just like, it's like there's a 50-50 chance. Okay, awesome. That doesn't help us. So right now, physicians are the gatekeepers. So you have to contact a physician. It's not something you can do sort of without any guidance from the medical establishment. And the problem with that, in my mind, and in terms of the introduction of implicit bias, is that they get to decide who's worthy of medical aid in dying. The physician gets to. And it's not to say, I'm not trying to place blame on physicians at all. I'm not trying to say that anybody's sort of on purpose bias, but it's that implicit bias piece. The possibility of opening that, to me, is tricky. I don't see a different way of doing it, because I think that that's part of the slippery slope is, oh, sure, you can go and, you know, do this to yourself without sort of permission, and that sort of opens up the suicide piece again. So then in terms of access issues, it's not covered by insurance in the US, so that it can cost anywhere between $1,500 and $1,800 for the medications, and that can be a barrier in and of itself. We talked before about the ability to swallow, the ability to open bottles. There also is finding doctors who will help. So there's a lot of I won't say a lot, but there's a good amount of doctor hesitancy, just in terms of perhaps they don't believe in it ethically, they don't believe in it spiritually, they just have a hard time with the concept. And so they may not be willing, if a patient approaches a doctor in a state or in a jurisdiction where it's legal, the doctor may not even offer it or respond positively. So the patient then has to go and find someone else. And I put others as a question mark because I don't know what your thoughts are on access issues, and because I just wanted to open up the discussion and to see if you have thought about, if this is something that you've thought about, if there are pieces that I didn't cover. What I'm hoping really to do is take back to our research group. We have a PhD student actually who's comparing suicide rates in jurisdictions that have medical aid in dying versus ones that don't. So she's looking at it that way. But I'm wondering if there are just things from a patient perspective that I can bring back to our research group and just sort of open the conversation with them and make sure they're keeping the patient perspective in this as well. Because I think that when we talk to the psychiatrists in our group, they often at least 2 conversations we've had with it. We have 2 psychiatrists, or a psychologist and a psychiatrist, and they have both said that if the patients who they've talked to, if they can take the if they can make their patients sort of feel like they can handle or not feel overwhelmed with what's happening in their life at the moment, then they don't have a desire for medical aid in dying. And then I spoke with a friend of mine who's a therapist, and she said, so the other side of that is sometimes when you treat the patient's depression, so they're not depressed anymore, they still are very committed to the idea of medical aid in dying. Like they don't let go of that. So in our research group, we have this sort of prevailing opinion that if we just make sure people aren't depressed, they won't want to kill themselves. And I think it's slightly misguided. So again, sort of cultivating these patient opinions and trying to make sure that our voice is centered.
Jen, one of the things that strikes me is just the verbiage that your team uses, because I have been very active in we call it death with dignity here in California. And the verbiage, people want to kill themselves, is not the verbiage that we use. And so I don't think it's this, if people aren't depressed, they don't want to kill themselves. What we're looking at here is people having choice, and people having autonomy, and people having literally the right to die with dignity. And so, yeah, so I want to bring that out there. And then again, one of the things that we push on when we talk to legislators, and when we talk to people who really do see this as an ethical thing, oh, you're helping people kill themselves, is we are generally a very empathetic creature. Humans are empathetic. We have pets. We care for our pets. When our pets are suffering, we think the right thing to do is take them to the vet and aid them in death, because we know that death is inevitable, and what we're trying to do is reduce their suffering and limit their suffering. And so we spend a lot of time talking about how you think if we can treat a loved pet like that, we could probably allow individuals to make decisions for themselves to kind of do that as well. So
right, and the writ I'm reading about, the pushback to that is because that's the pro death with dignity side, and then the pushback to that is the slippery slope aspect. Well, who gets to decide? Or is it one of those things where suddenly someone else is going to make the decision for a vulnerable person? And so that's the advocacy groups seem to have really sort of kept in the lane in terms of making sure that they keep in their lane to make sure that in New Jersey it's physician aid in dying or something, but to keep that really narrow perspective, because if it gets too wide, it's that fear of the slippery slope fear. So how do we combat that slippery slope? I think is part of it too, or the concept, the perception of the slippery slope.
Of a slippery slope, yeah.
Rod's got his hand up.
Okay, that was good, Jen. Thanks for pointing that out. I think there's a few little things I'll say here. One is euthanasia. It's sort of from the veterinary area, and I'm not sure that's a great term for it. In Australia, it's called voluntary assisted dying, and a couple of our states have introduced it. There's protocols with doctors, etc. But I think if we're talking about cancer patients, what we're really talking about is palliative care with pain relief, and the patient and everybody at some stage is just saying, right, we just ramp up the pain relief, the morphine. And that's such a common thing. I've spoken to people in hospitals, the nurses and the doctors, and they said, you just don't realize how much assisted dying goes on in the system. And but regularizing it is very important. And I think I'm surprised that it's not, California has something different. Stacey, did you say?
Yeah, we have. So first of all, the whole hospice, when you're in hospice care, especially not necessarily at home hospice, but you know, elsewhere, yes, we do see a lot of people who are helped with pain medication. The death with dignity pieces here were more for individuals who know what's coming. Can be cancer, but can also be a lot of other degenerative diseases. And a lot of times, especially neurological ones, because when they start to lose things, it's not just loss of mobility, but it's truly it's loss of, you know, function. It's loss of cognitive function. It's loss of things like the swallowing, like the ability to swallow. And as Jenn mentioned, the way that the law was written here is you actually have to be able to, as the individual who would like to, you know, choose to die on your own terms, you have to be able to swallow that medication. And so it's not something where you want to wait until you're in hospice, because now you've already lost kind of control of that degenerative process. But it is only people with terminal illnesses. It is only people who have physicians who acknowledge here in California, you actually have to talk, you have to have psychosocial counseling too. So it's not just a matter of you find a doctor that says that you have a terminal illness. They have to determine that you are of sound mind, that you are not depressed, that you're making this choice and have all of the information. And then California has a 15-day waiting period once all of this has been approved. And there was just a bill introduced last month that is looking to do away with that waiting period. So again, individuals have to work so hard to get to the point where they can actually get those prescriptions, and then they have to wait 15 days. And it's just, yeah, it's a slow roll, and it's challenging, you know. And as advocates, I think we say, be a self-advocate, you push for what you want, push for what works best for you and your family. And when it comes to kind of the ultimate last choice that you have, you know, trying to get policy and operations to support that is.
And I think now that you mentioned family, we have a friend, and most of us know her, and she's going, you know, to end of life. And I think one of the things that really worries her is her family, because she called another friend who lost her husband, and this friend was the caregiver as her husband, and she knew, you know, all the things she went through. And she called her like a month ago for her to explain how it was in the family and what the family could expect. And what I can perceive is her worry about family taking care of her. And she started, and when you mentioned, you know, all the time they have to wait, I think it was because her daughter keep us posted. And she decided like a month ago that she wanted to explore the end of life assisted. But now with the morphine or whatever, she cannot swallow. So now the things that you mentioned, Jenn, make sense. And I think what triggered all that when she wanted the system was about she was in disposable that, you know, underwears, and they had to clean her and all the things, and that is really tough. And she said, damn it, I live my life, I want to die on my terms. And the sad thing, you know, she got so sick now that she's not going to be able to do it. So it's awful. I hate cancer anyways.
I know it's such a hard, I mean, it just is such a, I mean, like Stacy was saying, the whole idea, you know, you can treat your dog better than you can treat our people. Like, what is wrong with that? I feel like it's not humane. We don't treat people humanely at the end of life.
I think a lot of it is wrapped up in our society, and I'm only speaking for the US as a whole. I know that there are cultures that deal much better with death, but
True.
The way that we talk about disease, the way that we talk about illness, it's always persevering. It's always being a warrior. It's always winning, and it's always this concept of cheating death, when in reality that's just not possible for any of us. And so I think in order to really have broad support, bigger than the 9 jurisdictions that we currently have, for people to have choice, and to do it in a way that's not going to be detrimental to life insurance benefits and things like that. Because you're right. I mean, people can just choose to overdose on pills, but if it's deemed a suicide, they have now taken all of the financial things that they put into place to benefit their family, and those go down the drain. And so it's a really, really hard choice, is, you know, but I think there's so much to be done in how we talk about death, how we talk about dying, how we talk about advanced directives, how we talk about, you know, how we want to live, and dying is part of that. So a lot of stigma, I think, to overcome.
And this euthanasia, I didn't come up with the euthanasia underground. This was actually in Katie's book. And my understanding is in Canada, they call it euthanasia. So I hear you, Rod, in the sense that it's not a kind word, and we do equate it then to pets, but in some ways I feel like euthanasia is okay, because we understand euthanasia as an American culture. We understand euthanizing our pets, but they, in terms of that suicide piece, if it comes down to that one of the things that culture does, that sort of hidden underground culture, is sort of talks to their people about, okay, so if you've got, you know, whoever, your family member all set up, as soon as it happens, go to the store, buy something, get a receipt, so that you have an alibi. Like, it's down to those types of things, because in addition to missing out on the life insurance, the really awful thing is if you get charged with killing them. So it's how to put the pieces in place to make sure that doesn't happen too, which kind of like blew my mind, because I feel like, I mean, randomly we've all made pacts with friends and stuff about, yeah, I'm not going to let you waste away. Yeah, I'm not going to let you. But then when it comes right down to it, it's like, well, how do you do that for people? How do you actually do it? So, yeah.
The other thing I think we need to keep in mind is, you know, there are people who just kind of say, you know, morally it's wrong. And I think we tend to say, you know, or me, I'm speaking for me, I'm like, whatever, it's not your life, right? But people who have a very strong faith where, you know, thou shalt not kill, I think it becomes a very challenging conversation. And in order for those people to feel like, you know, I don't know if you guys are religious at all, but I'm not, but I'm a fan of Pope Francis, because I think he's just a good human. And he came out and he said to all of the people who are of the Catholic faith, we have vaccines, and we know that some of them were developed with fetal tissue. And as a dogma, we disagree with that, but you will not be held responsible. Your place in heaven, or you know, where you believe you're going, is not in jeopardy. And so please take whatever vaccine. And again, I don't live in that religious world, but I really do think in order for this to get broad support and to support people, we have to work with you know, homes of faith, and we have to understand what their concerns are, and then we have to work with the leadership in, you know, churches and synagogue, you know, those types of organizations, to say, how do we make this right for your people? Because, you know, you don't want your people to suffer either, right? And we're not going to be able to avoid death. So I really do think it's a super complicated conversation, and one that has to happen in a lot of different places.
It's really, and one of our, Rod, is your hand up, or is that just up from before?
No, that old hand up. Sorry, I didn't put it down.
Oh, no, I just wanted to make sure. One of the things that we look at in our research group too is financial toxicity of cancer care. So when you look at the trajectory of how much cancer care costs, the last 6 months, when you look at Medicaid spending, the last 6 months of a person with cancer, that's when their life is the most expensive. But conversely, the first 13 months of if they have sort of a diagnosis and then a a metastatic diagnosis, the first 13 months are very expensive, and then there's a lull, then there's the 6 months before death. So I kind of made again, black humor is my friend, right? So I kind of made the joke that we were talking about this medical aid in dying, and we were also working on this financial toxicity, and I said, well, I think medical aid in dying is like cheaper than the last 6 months of your life. I mean, whether it's covered by insurance or not, because $1,500 is a whole lot better than whatever that could be $20,000, $30,000 that you have left to pay depending on your insurance. And so we're actually having a little bit of discussion in our group about connecting the two concepts. That I'm not saying that financial needs to lead anybody's decision for medical aid in dying, but to that point of why do we push people into you have to try everything, don't give up, and you have to it's okay, your doctors haven't used everything yet, let them tell you what's next. And meanwhile, the toxicity is higher in terms of the physical toxicity, the financial toxicity is higher. And if we could keep this conversation, if we did a better job of talking about death as a part of life, I think we could do a better job also at controlling costs at end of life, which is very, very esoteric and hard to say in sort of general society, but I figured I might be able to get away with it here.
Get away with anything here.
True story. And I think you have to understand your audience well, right? I mean, one of the things that you mentioned in the presentation, and I only know California, is those medications are not covered. So immediately this becomes an option for people who have disposable income. I mean, $1,500 is not insignificant, and most people don't have that lying around. So already we've split the community and said, do you live in a place that allows this? And two, do you have the financial means to make it happen? Well, that sucks, right? And so, no, I don't think this needs to be a help yourself die early and save lots of money. That doesn't need to be the conversation. The conversation, though, can be, hey, healthcare, people deserve this choice, and these are the reasons why they deserve this choice. And oh, by the way, if you cover it and make it more accessible, well, you care about your bottom line. It's going to save you money in the end. So
right,
that's where I think the financial piece can fit in. You have to talk about what people care about.
I know it's always about the bottom line, right? Like it's always about the bottom line.
So Rod, yeah. I'm just curious, in Australia, what's the prevalence like? What's the uptake like? What's the societal perspective? We've come a long way since Dr. Jack Kevorkian, but does Australia have kind of a more open mind about this?
Yeah, public opinion polls very much up in the 70+%, mid 70% in favour of assisted dying. I think some of the governments have trouble framing the legislation to suit everybody. As I said before, the comparison with veterinary science is a bit different. Pets can't tell you their pain, but people can. So a lot of these decisions, I think, in humans are made, close to the end when they're really pretty comatose. And now here, of course, we have advanced health directives, which I'm sure you have in the US. So the doctors just look at that and go, right, this person has signed off on, not being resuscitated, not having extra pain that they should not have to bear. And so we'll take over from here. So that's the sort of voluntary assisted dying is really just the getting your wishes accepted. And you've already said that a long time ago. So you've taken into account all the different things might happen. In fact, when you fill out that form, you have many different questions. And so once that form ends up in the hospital on the palliative doctor's computer, they go, right, this person has really signed off on this. So it's not it's voluntary assisted dying. It's not really euthanasia, and nobody really, I think, wants to be euthanized. I think it's all about individuals, and yeah, so it's pretty much on the agenda here. In answer to your question, thanks, Stacey.
What about at home? When people are in hospice at home, is that something that is then possible?
It is possible. It is possible. Again, a friend of ours, her husband did that at home, and the drugs were prescribed by the local doctor, GP, and they were administered by his wife. They were oral. There wasn't injections, and but it took a while for him to get that. Going through the local nursing service wasn't good enough. Their policy is just keep you alive at all costs, and so this was, I think, it can work at home. It's perhaps you've really got to be luck out with your doctors, really.
So wait, you it doesn't have to be the patient. It's the patient themselves who administer the medication. It can be a family member.
It can be a family member if it's prescribed drug. Who's at home to know whether the patient, screws the lid off, or if someone sitting with you screws the lid off? If you get what I'm saying, I think it's different in a hospital, obviously. Yes, shush.
Things we're not allowed to say out loud
In this country.
in this
I
country.
think we can say anything here, can't we?
Well, in Canada, the rules are, because a lot of the literature cites it's Canadian studies, because it's just legal across the country. So you have this huge sample pool of people, but it's very loose in the sense of a doctor can say you're diagnosed with MS, multiple sclerosis, and you're diagnosed at 25 or 30, let's say, and I don't know what the average age of diagnosis for that is, but you can, if your doctor writes you a note and predicts that your death is 10 to 20 years out, you can have permission in Canada. So you can make, just like Rod is saying in Australia, you can make the decision early out, and it's just then part of your care. It becomes part of the care that's for you. And then but then that raises sort of the different question when you're talking about dementia, because people can choose it for dementia as well. So if you make a decision of when you've been diagnosed with dementia and you make this decision, and then 10 years later, you're at the point where you've said, I don't remember, say your parameters were, I don't remember who my husband is, I don't remember where I live, I don't, whatever you've decided are the things that make life unlivable for you. But then the flip side of that is, what if from the doctor's perspective, what if the patient sitting in front of them is a smiling, happy patient in that moment?
Yeah.
But it's because of dementia, and because they've forgotten the gravity of what's about to happen. So it becomes this sort of questionable piece too. So there's no perfect system, I think, but having decades to plan something seems an improvement over the American system of, like, California's 15 days, New Jersey's 30 days. I think there aren't any states that are more than 30. But
California is 15 days after you have those two appointments, and those two appointments must be at least 1 week apart. And then you have to find a pharmacy that is willing to fulfill the prescription that has been prescribed. So it's not
easy process. It's not easy at all. It's sort of.
I was just going to ask a question. So Sandy, Roberta, Barbara, and John, I think all of you live in jurisdictions where it's not an option at this point. Is this something that in the community you see interest for, appetite for? Are people working on it? Sandy says no.
I can only speak. I can speak from the standpoint of the social network and the many, many people affected by life-limiting illnesses, particularly in our advanced cancer communities. And just as you were talking, Jen, I was hearkening to so many discussions. Some take the
Which you put in
form
there, thank you.
in our discussions in lung cancer community. I remember a gentleman, and he actually coincidentally was from Maine, which is where I'm living right now, who wrote and was very, very active in the social network, as I know most, if not all of you are in and can relate to the comradeship and the closeness. And he, he said a scan went bad or the cancer has progressed to some bad news. I'm out, folks. And for him, out was not seeking active treatment. He did not get on a plane and go to Washington or wherever, but he made that saying I'll stick around and I'll tell you how it's all going, but I'm sick of being sick.
Mhm.
And it was extraordinary to watch. Actually, the story ended up getting picked up by ABC News because, and I talked to him and got to know him some. His name was Jim Stanicki, and it was a fascinating life lesson to see the dynamic also in the community where there were a number of people who, I'm sure for very good reasons, were saying, Jim, you have to be a fighter. You have to battle on. And I'm sure they were saying it because they were going to miss their friend who they came to know online, or they thought that with a little bit more push might work. And he took it all with good. He did not say this is my decision or anything of that nature. He kept that positive spirit and would say thank you for your suggestion, which he did not. And he lived until he died. And I found it fascinating, and the stories about him, both in the community and by ABC News, I think touched on that. And again, if he had and I just noticed that you had written that the state of Maine has an assisted dying legislation. I suspect if that was in place, that would have been an option for that gentleman at that time. Although many in his community of people knit together by lung cancer were of different minds. And it could have been by faith, it could have been you got to battle on, it could have been other issues, worries about, the steps toward euthanasia, et cetera. You have to do what your doctor tells you. So stay on that treatment.
Mhm.
It's extraordinary.
Roberta or Barbara?
Hey, it's Roberta.
Hey.
I was going to say, not trying to be smart, but here in Pennsylvania, especially in the Black community, they don't even want to talk about cancer, let alone talk about death. So
Exactly.
Fair.
you know what I mean? I'm just keeping it real. So
Yep. So Roberta, how does and that's a great point. And we talked about communities of faith too. There's places where this conversation just doesn't. There's no real easy in because people don't even want to talk about the first step. But when people are dying and suffering and feeling that, and in the Black community, in the Pennsylvania community, is there that moment that says, yes, we know we need better cancer treatments. Yes, we know we need, to eliminate some of these health disparities that are preventing health equity. But at the end of the day, we're still going to have cancer for a long time, and people need to have more choice in the way they die, or that's not even happening.
well, I don't know what's happening in Pennsylvania with regards to that. That's something I would kind of have to look into, but I just know in the different communities, I hear a lot of them, especially in the Black community, let God take them. When God is ready for them, that's when they'll go. So that's why I said, for the most part, it's just dealt with until, as they say, God take them home.
Yep.
But if we can't talk about cancer, how are we going to talk about, end of life? And I'm just, like I said, I'm just being real about it. So, but I would like to see if Pennsylvania, if they do have anything of that nature, like with New Jersey just coming on board. So I will look into that, just for my own personal self.
Yeah.
But I don't know, with the communities, it's kind of like taking baby steps.
Yep, that's sometimes all we can do.
Yep.
Shuffle forward.
I mean, this is for anybody. What do you think about what's about involving family in the decision? Because it can't be a bubble decision, right? Like it can't be something the patient makes in their own bubble. In my opinion, it has to be something that's really talked about if the patient has a family to talk about it with and that kind of thing. Any thoughts
And
on
again,
that? I know.
and again.
Yeah. The people that
Got
I
you,
know
Bobby.
who participate, who've actually gotten their prescription filled and who have gone down that path, and of the actually more than 2 handfuls of people that I know that went down that path, only 2 of them at the very end were able to take that option for a variety of reasons. One is what Barbara just talked about, right? There's a point where it's just it's everybody's waited too long.
Tonight. Yeah.
Right?
Mm.
Every family that again, these are people that I know, so I've got more insight into that. It was a family discussion, and it was actually, this is the part that makes me sad. They didn't want their family to have that as they wanted to be there. They wanted to be there at the end. They wanted that death that was like, I have looked each one of you in the eye and I've told you that I loved you and it's my time to go. So the short answer to that is, I think the families are involved because this is not something that anybody that I have seen walk through all of the steps has been able to do, on their own or wanted to do on their own.
Yeah, there's a movie now, and I think it's on Netflix, something of Blackbird or Bluebird or something about a bird. And it's this woman I can't remember the name, but it's this woman who's dying, and her daughters are, questioning why she wants to end her life assisted, and it's an assisted death or whatever. And it deals with all the issues you were saying, Jen. If I remember the name sometime, I'll put it in the chat. Or I'll look for Netflix and then I'll let you guys know next week. But it's, and in Puerto Rico, people are very conservative. So that is not an issue that is discussed at all, because people comes from a very religious, like Roberta was saying, very religious background or whatever. So it's like offensive to think that you will decide to die before it's your time.
Yep.
I'll add only, Jen, one thing that harkened to mind is a wonderful memoir by a young end-of-life care specialist physician, Sunita Puri, who's a rock star and then some. And she has a couple of anecdotes in the book about, and this is palliative care, not necessarily but when, active treatment versus comfort care, and what is that definition? So as sad to say, people don't know what they don't know about palliative care hospice, let alone what is a death with dignity process look like, as Stacy described to us. There's a couple of really heart-rending types of discussions of, she shows up and it's the physician who's kind of cleaning up the mess because everything else failed. So she's coming in with a daughter or son or daughters who can't even agree themselves. And there's a parent in bed who is clinging to a cognitive state, but not necessarily. So you had a mess. And she wrote really, really thoughtfully about the clinician role in there. Where do you even begin? Particularly we're going, okay, let's be on the same team. What do we have in common? You want your father to do what, and it was extraordinary and tough and so eye-opening. And I'm sure that's replicated over and again, where there isn't the same team and the family is pushing in one way. And then maybe even within the family, there's not agreement and a cohesion for what's best for the patient.
Mhm.
Tough, good read, tough read.
Can you put that in the chat? Because I can't spell it on my own.
I will. Is it the good? I think it's The Good Night. I should know her book. Sunita Puri. I'm just doing that right now because I.
Oh, there we
Well,
go.
reminding
Okay.
me to copy the chat because I regularly forget that. So
I know I go through and open everything that's in the chat so that I can go back to it later. But yeah.
if anybody wants to save the chat on their own, you can just click those little three dots and save. But I will pull these out and I'll attach them, Jen, when I send the recording to everybody.
Perfect.